Good evening. Hope you are doing well. Today we are going to discuss some conventional and old-fashioned plates, but they are old-fashioned but still in use. These are dynamic compression plates and Buttress plates and neutralizing plates. They have different names, but the same, almost the same function. They are made of metal, usually stainless steel. Uh, at the end of their era, some titanium versions were also available, but they were usually made of stainless steel. And actually, they revolutionized the treatment of fractures, but they still have many problems. Uh, they were complete. Logically, they were perfect. They fit the fracture to some screws, and they hold held the fracture in place and held the fracture unit. Have unit. These plates work based on the stability of the fracture site. Without the stability in the fracture site, you will not have a unit. Because without the stability, there will be motion in the fracture site. And when there is motion, there will be disruption of any tissue that is being formed in the area. So the healing mechanism that is working in the area and is producing new tissue will be disrupted. It will not lead to healing. You may have experienced some cuts over your knuckles, in the fingers or in the over the knuckles, and uh, I'm sure you have this experience. If you use your fingers repeatedly, this wound, these cuts, will open with each flexion, and then they close with extension. And unless you keep your finger immobilized, this area will not heal, because anytime you flex your finger, this part will be disrupted, and the granulation tissue that is forming in and the healing tissue there will be disrupted. So at the end, you will have a large scar and a delay wound healing. The same thing happens when there is not stability in the fracture side. You are familiar with the concept of a strain. A strain is the ratio between the change in the length when you apply the stress to an object, the amount ratio between the amount of change in the length of that object to the uh, original length is called strain. Delta L to L. The same thing happens in fracture gap when we don't have stability. The length in the fracture gap, the original length is L, and when we have instability, there will be a change in the fracture gap, which is delta L, and so we will have a strain here. Based on the amount of strain, we can define different patterns of healing in our fracture site. If the strain is less than 2%, it is called absolute stability. There is almost no motion in place, and it is the ideal environment for healing. If the strain is between 2% and 10%, it is less ideal for the healing, but it is easier to achieve. And if it is more than 10%, that is the condition that we don't have. It leads to blockage of the union, which we call non-union. It inhibits bone formation, and instead of bone, there will be some soft tissue and some cartilage bone here, and the fracture will never unite unless we perform a second surgery. So, if we look at this formula, consider this is the strain, this is delta L, and this is N. If we decrease A, X will be decreased. If we increase A, X will be increased. But for denominator, it is opposite. If we decrease E, it is the original length, and what we are talking about is the original length of fracture gap. X will be increased. And if we increase P, X will be decreased. So now let's use this concept in our fracture. If you have a small fracture gap, and even if we have a very, very small motion in this area, since the denominator is very small, the strain will be hard because the ratio between delta L and to L is very high because L is very small. But if you have a large gap, since L is very large, whatever delta L is still much smaller than L. So a strain will be low. Although the motion in this type of fracture may be more than this one, but the strain is less because L is very large. Generally speaking, we have two kinds of bone healing. The one that we like too much is primary bone healing. It is a healing without any scar tissue. It is direct bone to bone healing. And it happens when the strain is less than 2%. It means that we need a very rigid stability here to prevent any motion, which is not easy to achieve. But if you can achieve it, which is possible with the plating, it is a perfect treatment for us. It usually happens, as you see here, in transverse fractures, the fractures that have a transverse pattern, or very short oblique fractures that we can compress them together. But if there is a gap in the fracture side, or the fracture like this one, and some fragments, we call these fragments comminution. And we call this fracture a comminuted fracture. If we have comminution or extra fragment, we cannot compress this fracture because if we compress it, the length will be lost. We have shortened. To keep the length of the bone, we have to keep these fragments in place, so we cannot compress them. When we don't have compression, we don't have primary bone healing. We have secondary bone healing that we discussed very briefly yesterday, and we discussed both the healing types in another session in detail, and we discussed different factors responsible for them and how they work and how we can augment them. We have a session on them, so I don't get deep into them here, but just to become familiar, when we have comminution or we have a fracture pattern that we cannot compress, we have secondary bone healing, which first there is a hematoma, and then hematoma gradually changes to soft tissue, and then cartilage, and at the end, soft bone, and eventually to hard bone and spinal union. But there will be something called callus. You see here, there is no extra bone. But here we have some extra bone, which is called callus, and gradually it's remodeled and formed, and returns to its original shape, but for some time after fracture healing, they remain in place, and we can see them in X-ray. So secondary bone healing happens when we have more than 2% of strain at the fracture site. But it must be less than 10%. If it is more than 10%, there will be no use. Many fixation devices can provide this type of stability, like external screens or tabs. Even some compression plates that I said before, they are ideal for rigid fixation and providing primary bone healing. If they are using specific mechanism called bridging mechanism, they provide non-rigid fixation, and they can lead to secondary bone healing. External fixator or non-rigid fixator, so they lead to secondary bone healing. And the US version of plates, which are called locking plates or lock plates, they are produced based on providing secondary bone healing. They don't provide rigid primary bone healing. to discuss why they don't provide. Here we see we have different types of fracture. This is a transfer fracture. This is incomplete, or in young people we call it green stick because it's like breaking a green stick. And you see the green stick when it is fresh, you cannot break it completely. It's just a fact. It happens in children bone, but in adults it is always complete. It can be transferred, it can be a spiral or oblique, or it can be comminuted. That's multiple fractures. These are the patterns, common patterns of fracture, oblique, or spiral is longer than oblique. And if the fracture is open to the external environment, if we connect to the external environment with the skin, it's called compound or open fracture, open to the external environment. We have one concept we were discussing called gap strain or fracture side gap strain. And if we use the compression plate and we compress the fracture, actually we don't have any gap here. So L is almost zero or close to zero. So if we have any amount of, even a very tiny amount of delta L divided by L, since L is very small, the result will be very large. So at first we compress this fracture, but gradually, sometimes in our fracture side, due to the injury to the vessel, the ends of the fracture start to resolve. So there will be a gap here, and this gap associated with a little motion in the plate and the bone will result in a high strain. This fracture was designed to be united or to get union by primary bone healing. But due to resorption here, the biomechanical fracture changed, and you see there are some callus formation, which means there is secondary bone healing. And that's only because high strain in this tiny gap here. Our plate and fixation is not stable enough to provide primary bone healing. But secondary bone healing is our current intention in all fixation devices. We don't want to rely on primary bone healing because primary bone healing gives absolute rigidity at the fracture site, in which even small instability due to this resorption results in secondary bone healing, and we lose the primary. And the problem with this intention for providing absolute stability here to fix the fracture to have primary bone healing, you need a very rigid structure at the fixation. So when we have a very rigid structure, this rigid structure bypasses the bone for load transfer. So the load passes through the plate instead of passing through the bone, because this structure is very rigid, and the load passes, this is a root. The load passes through the most stable root. So the plate is more stable than the bone. So the load bypasses the bone, and bone will not tolerate any load, or at least it uses most of its load. So gradually the bone around the plate starts to be resolved. And if you can the bone around the plate, and if the plate is in place for too long, the bone may break round. And when you remove the plate, you have a weak bone that patient needs to be careful about it because it can break easily. That is why we had problem with this plate. If we use this plate correctly based on the biomechanics, and we got the primary bone balloon, the fixation device was too rigid for the bone to be biomechanically sound. And if we lost the stability and we lost secondary bone balloon, it was prone to failure because there was instability here and there were motion. These two were not locked in the plate. They could toggle in the plate. The motion in the bone would fail the plate. So we had two problems. One side very rigid, biomechanically mechanically very good, and it led to primary bone healing, but biomechanically it was not good. It would need to treat prosthetic healing. Then we want to talk about any device, the environment, or anything around the devices. In orthopedic surgery, we use pre-prosthetic, for example, pre-prosthetic infection, pre-prosthetic bone. So it was not biomechanically sound because it would lead to pre-prosthetic bone results. These plates, when I was a resident in orthopedic surgery, he had only this kind of plate. And they inserting one of them was one of our greatest achievements in the first or second year of residency, and the very far to use them. They are called dynamic compression plates because while you are inserting the screw, you can apply pressure in the fracture site. You will see later in the video how they work. They have an oval, hole. So when you fix the plate on one side and the screw is in the center of the hole, as you see, on the other side of the fracture, you put the screw in an eccentric way away from the fracture side. So while you are tightening the screw, the head of the screw contacts the tip of the hole and gradually slide toward the fracture side. And while the screw is sliding toward the fracture side, it moves the bone with it. So the whole screw and bone will move toward the fracture side, and the fracture side will become tight. And it was a nice thing to have compression in the fracture side, and it was great at the time. But as I said, when we put several screws here, it became a rigid structure with its own problem. It is still used for some small bones, and I use small bone compared to femur and tibia, but they are not small. the bone in psoas, radius, and ulna. And they work perfectly because these two bones are not under much load. So if we can cross the patient and rely on the post-operative correct protocol, these plates are still working for our bone, but for other bones which need great load tolerance, we do not use them anymore. These plates rely on a rule. Since the screws are not connected to the plate, they are connected to the bone, the plate can move. How we prevent the plate, the movement of the plate? By compressing it over the bone. So the friction between the plate and the bone prevents any movement between the plate and bone. And this is how it works. So we insert the screw, compress the plate against the bone. So there will be no movement between the plate and the screw, as between the plate and the bone, as long as this compression is held. The compression between plate and bone. If there is any problem with these screws, we know screws are tightened in the bone. If one of them is loose, this compression will be lost. So the friction between plate and bone will be lost, and the bone can move over the plate, or plate can move over the bone. Another problem with this plate is when you apply the load on this bone, and there are several screws here and here, the load is tolerated by the first screw, passes through the plate, and passes through the last screw and enters the bone and continues. So all the loads are tolerated by the first and last screw. And the middle screws are under very, very small load. It continues until these two screws are safe. And then this load transfers to the next one, next adjacent, and then next one. That is why, after a while, these screws can fail one by one if the first patient is putting a lot of load on the stone. And at the end, the plate screw structure will be failed, because the screws are under load by one, not all together. This is very important because you will see in the next session about locking plates. That is exactly the opposite. The load is tolerated by all the screws at the same time. So this was another problem. And the last problem was biological. The mechanism with plates prevent any bone motion is their friction. The friction between plate and bone. Because for the reason for this friction is compression of the plate over the bone. This compression means direct contact between plate and bone with forceful compression. It means that the blood vessels over the bone beneath the plate are under compression. So when you compress the blood vessel, you are closing that blood vessel. And after a while, it will die because it's not working. When there is no blood vessels here, the bone beneath the plate starts to die. And when we remove the plate after a while, when the fracture is adrenal, a layer of dead bone is present here, and the body needs to remodel it. It adds to the goodness of the bone. Besides the flesh shielding, which decreases the mass of the bone here, this dead bone also leads to weakness of the bone. So you see, there are several problems with the plate. At their time, they were perfect because we didn't have anything better until some names called interlocking names were introduced. And they were first introduced for TBI and tumor. Later, they were introduced for tumors, and then many centers were working to introduce them for forearm, but they are not successful. But they are still associated with some problems. So a new version of plates was introduced called Lucky. And now in orthopedic surgery, all the plates are Lucky. All the just an explanation. This plate is a Lucky plate, and the screws are Lucky. But I couldn't find a better image to describe what I want to describe. So please consider this plate as a conventional plate, okay? I said before that usually for transfer fracture and short focus fractures, the dynamic compression plates were used and we compress the fracture side. So like here, and we compress it and we put screws on both sides. But sometimes we have a large comminution area. You have several fragments, and if we approach this area, we open this area and put all these fragments back together, we will have a very nice X-ray. Everything is in place, but these fragments will lose their vascularity because we have opened the area and we have manipulated these fragments, so their attachment to the soft tissue is lost. And also they are separate fragments, so they have no connection to the other parts of the bone to receive vascular vessels. So they will not have any vascular supply or blood supply, and after a while they die. So we have a large defect here, which happens in anatomic reduction concept, which was introduced at first for the dynamic compression plate, and many fractures were complicated by the absorption of the parts, and there were huge gaps in the fracture structure. So a new concept was introduced called biology fixation or breech plating. Actually, in breech plating technique, we breach this area. We leave this area to itself. We have nothing to do with this area. We don't open the fracture side. We don't see the fracture side. We align the proximal part and distal part together and leave this area to itself to remodel. In this way, we keep the vascularity of these segments and they continue to live. So they are alive and they don't need to be replaced. They just need to provide some union at their edges. So when these edges are united, we have at first we have a misshapen bone. The X-ray is not beautiful. The patient may say uh, it's not correct, but biomechanically it's correct because the proximal part and the distal part are in correct alignment. And gradually we continue loading on this part, these segments in models and become until into the original shape. This is called breach plating. It breach the fracture side and we don't open this area. By breaching, we have a screw on one side of the fracture side and a screw on the other side. And the distance between these two screws is important for us. This is called working space. You will see later how you working space. When we use dynamic compression plates, they provide a stability problem, but this is not all they do. Yes, they provide immobilization and stabilization, but they also transfer load for us. Most of the load on the fracture side will be transferred through the plate. Some of them bear all the load. Some of them share some of the load. So we have two types of the plating technique. Load bearing, which bear all the load, load sharing, which share some of the load with the body. And you know now that sharing the load is better biomechanics. We don't want to use the load-bearing device around the bone because it carries all the load and the bone carries none. So the bone gradually becomes starts to dissolve. So the load-sharing devices are best devices for us. Sometimes you have to use load bearing. For example, in this fracture. If we want to use load sharing here, some part of the load must pass through the bone. But since there is no contact between these two ends, it will bend here. And the fracture and the plate gradually starts to bend and it will fade. So sometimes we want to use load bearing and intention. Otherwise, the best choice is load sharing devices. And as we discussed before, the plates can provide compression at the fracture side, and they compress the two fractures together, and in this way they provide stability. Sometimes we have enough compression at the fracture side, but the structure is not strong enough. In a fracture like this, an object fracture, if we put one or two screws to hold them hold together, it is enough for union if there were no load on this bone. But if we want to apply load on this bone, these one or two screws are not enough. So we use a plate, a very small plate. It is not strong enough to hold the bone under normal condition, but since we have the screws in place, it only needs to neutralize the excessive load on the bone. That is why it doesn't need to be so strong. And this mechanism is called neutralization. Neutralization plates. They are not here to fix the fracture. Their primary fixation mechanism is this screw. They only neutralize. They provide no compression. They only neutralize the force. Another type of plating mechanism is called Buttress. You know what Buttress means. Something you put under an object to hold it in place. They exactly work the same. We use the Buttress plating for fractures around the joints, and they hold the fragments in place. Sometimes they provide fixation, sometimes they are there only for Buttress. And the last mechanism by which the plates work are bridging mechanisms, which is discussed. If we want to use a dynamic compression plate, it is original use. You see here, we discussed, we put central screw, central, I mean, in the plate hole, it is central. As you see here. On one side of the fracture side, and on the other side, you put an eccentric screw, which is away from the fracture side, away. And then when we tighten the screw, it gradually slides over the side of the hole, which is oblique, and pushes the bone towards the fracture side and provides compression. That is why we call it dynamic compression. As you see here, this is a typical dynamic compression plate. The holes are oval. You can put the screw on this side, you can put the screw in the middle, or you can put the screw on the far side. If you put it on the far side, it provides compression. If you put it in the middle, it is neutral screw. If you put it on the near side, it provides distraction. It moves the fractures away. Sometimes we need, for example, a cat is override, and we want to increase the length a little bit. We can use this mechanism. Instead of putting the screw on this side, which is away from the fracture side, we put it on the side of the hole that is close to the fracture. And when we tighten the screw, it slides over the wall of the hole and moves away from the fracture side. Moving the bone with it away from the fracture side. So if the fractures are override, you gradually correct it. These are some tips that we use with these text. We have a concept in using the plate, which is called tension band mechanism. Consider you have this structure and you are applying load eccentrically to this structure. As you see here, one side is under compression and the other side is under tension. If you want to prevent it bending in the structure, you have two options. Putting a fixation device on the compression side or putting a fixation device on the tension side. If you put the fixation device on the compression side and you apply load, still this device will be under bending load, and this bending will eventually bend this plate and fail the structure. But if you put it on the tension side, This eccentric load applied tension force to this plate. And you know, stainless steel and older metals are very resistant to tension. So the physiologic load in our body cannot stay the plate in tension. But something else happens. The plate remains in place, but now the fulcrum, instead of being on the compression side to provide the rotation of this upper part, now the fulcrum moves to the plate, to the fixation device. And when you apply the load, all the upper structure and lower structure are compressed together. So with this tension band mechanism, you are converting the tension load to compression load in the same structure. It may be plate, it may be wire, it may be an external fixator, whatever we use here on the tension side has the ability to convert the forces in the fracture side from tension to compression. And when we have compression force at fracture side, it accelerates the unit. The long bones in our body are not straight. Femur has 9 degrees of obliquity. Tibia has 3 degrees of obliquity. So when you have this obliquity, the load is applied here to the middle of the knee, but the femur is not in line with this load. So one side, when we have a fracture here, one side is under compression, the same as here. One side is under tension. So when we want to use the plate or fixation device, we must respect this rule, and we must put the plate under tension. That is why we always use the plates for femur on the anterolateral side of the femur, because this is the tension side of the femur. But in other bones, we have a problem with this concept. For tibia, the tension side is on the lateral side, like femur. But the lateral side, you cannot touch the lateral side of your tibia because it is under a lot of muscles, and the muscles, there are many nerves around there. But the medial side of your tibia is under skin, and you can not only feel it, you can touch the bone under the skin. And it's very easy to put a plate there, but it's biomechanically untight. If we want to put the plate on the lateral side, we have to squeeze a lot of muscles and risk a lot of complications. So we prefer to put the plate on the medial side, which is not the tension side, and with this, the failure for keeping the biology of muscles and section. This is one huge reason that the plating in tibia has been replaced by intramedullary ligament. This is one huge reason. Locking compression, locking plate, which is not the after today's discussion, we will discuss it next week in detail, but uh, just to see the difference. In locking plate, the screws are locked in the plate. So there is no motion between the screw and plate. But in conventional plates, we were discussing the screw can toggle. And if there is any motion between the plate and bone, the screws will toggle and it will fail the construct. You see here, in conventional plate, we compress the plate against the bone, and if we apply load on one side, it passes through the first screw to the bone, to the plate, and moves along the plate, and passes through the last screw to the bone. And these two first and last screws are under huge amount of load. So they may fail. When they fail, their function is transferred to the next one. And then the next one. So they fail one by one. But in locking the screw, the rigidity of the structure is dependent on the locking mechanism between the screw and plate. So when you apply the load, since there is no motion between the screw and plate, the bone distributes the load between all the screws, and these loads are transferred to the bone. And you see there is almost no contact between the bone and plate. There is no compression. And we said there are problems with this compression. So in locking plates, we don't have this compression. And the load passes through the plate to all the screws on the other side and then to the bone. So all the screws are under load and they function together. If they want to fail, they all must fail, not one by one. And it is much more difficult to fail all the screws together. But in locking plate, we have a concept called locking compression plate. This is why I included it in this session. We were discussing about the compression plate, the dynamic compression plate or DCP. Actually, if you tell the dynamic compression plate, you will see for a while what it is. But if you say DCP, they all know immediately what it is. They are more familiar with the name DCP and LCP than the something. We said dynamic compression plate have oval holes that allow some movement between the screw and plate while you are inserting them. In dynamic compression, in locking compression plate, they combine the locking the screw mechanism with dynamic compression screw. So these poles actually can accept one of two screws, either locking or conventional. When we use the conventional screw, we can apply compression the same as dynamic compression plate. But when we use locking the screw, it is only a locking screw and there is no compression. Sometimes we need it, and when we need it, we have it. You remember I said we have a concept called working net. It is the distance between the closest screws to the fracture point. When this working length, actually this working length is almost equal to the L in strength. It is the length, and you call it working length. If it is increased, it is a better condition for us. You see here, if you have a high working length, when now I'm not going to discuss the fracture side. I'm going to talk about the plate. Consider there is some bending motion in the plate. The patient is walking, and with each step, the patient is applying some load on the plate, and the plate is a little bit bent. But this bending happens along this length. And I am sure you are familiar with the fatigue concept. When the bending happens along the length, the fatigue happens later. But if the working length is very small, the same bending happens while the patient is walking, but this bending happens along this small length because the working length is very short. So what happens? This plate with a small working length will fade soon due to concentration of loads here and early fatigue. But this plate will tolerate the loading for a long time because the load is distributed along the working length. This concept is very important in the structure that we will use during the fracture fixation display. And if we don't know this concept, some surgeons don't know and they use all the screws so the plates fail after a while. Some companies have used have changed the design of the plate to prevent it because they say we cannot educate all the surgeons about this biomechanics concept. So they remove the holes from the middle part of some plate. So you cannot put any screw there, so the working length will be larger. But there is a problem with that. For each fracture pattern, we need a specific plate. And since these plates are produced by the company in factory, and you must have them in stock in your operating room, you need a large stock of different plates to be able to handle all the fractures that you cannot predict your pattern. But if you have a universal plate, you don't need so many plates in stock. You have one type of plate, and you can use it for all the fractures. So this problem was solved by removing the hole in the middle, but it produced some financial and starting problem. And again, you see here the bridging plate, not to discuss, but the Buttress plate. When we have a fracture around the articular surface, in distal tibia, in proximal tibia, in distal tibia, in distal radius, in all these areas, the fracture passes usually to a vertical line. And when we put it together, at first it is very easy. You can put a screw and compress the fracture. And everything is good. At the spot. These joints I named. Little joint, knee joint. These joints are under compression load, under axial load in this direction. So gradually, this part of the joint can slide down and be displaced because the compression here And the fixation that this screw provides is not enough for the load that is applied on this section. So gradually, this part of the fracture slides downward, and the reduction will be lost. The only part in our body that we need perfect anatomic reduction, nothing less than perfect is acceptable, is in articular fracture. In the articular fracture, because the cartilage is disrupted, and as we discussed before, we cannot regenerate the cartilage with our current technology. The only thing we can do is to put the articular surface and the cartilage surface close together in the perfect anatomic location and condition. So this part of the articular surface that is attached to the fracture, and this part that is attached to the main bone, we put them level to level and hope that they can, when they heal, a very small amount of scar tissue falls between them, and they can function not perfectly, but as perfect as possible. So to do so, we need perfect anatomic reduction. I said before, in other fractures in the shaft of the bone, in the parts that are not articular, intra-articular, the current concept is don't open the fracture side and cross 50 alignment. But here, it's different. We need to put everything in place. We have to find all the segments one by one and put them back. So any displacement here will disrupt this anatomic reduction, and it will destroy the joint. To support this screw, we use buttress plate. Buttress plate can have a hole to hold these screws, or we can use these screws outside the plate, but it's not important. The important thing is this part of the plate, and it holds the fragment in place. So when you apply load on this fragment wants to slide downward. But when it slides downward, it encounters the plate, which pushes the fragment toward the other segment. So actually, you are changing axial load into compression and to facilitate the unit. This is how buttress plating. It holds the fracture in place, the fragment in place, and converts the axial and shear load here into compression load. And compression load is what we want in our fracture unit. We discussed the neutralization plate. We said we fix the fracture with a mechanism like a screw or key or anything other than plate. But it is not enough, and we need something else to support the fracture. We usually use a very thin or small plate to hold the fracture in place while the unit happens. This is called neutralization plate or neutralization in time. We discussed all of this. Buttress plating, as I said, are used for intra-articular fracture. So anywhere that you have a joint, you can use a buttress plate, like in elbow, in shoulder, distal radius, the distal femur, proximal tibia, and the, again elbow. So we have different types of Buttress plates. The Buttress plates, previously they were only BCP type, but now they are locking plates. But the mechanism is still the same. And you see, these are some examples of the different Buttress plates designed anatomically for different parts of the body. They can be T-shaped, they can be L-shaped, or they can be in like this one, or this one. They are designed specifically for this section, like distal radius, distal femur, and they match the anatomy of the bone, and they perfectly work. Any question? So let's start from here.
Hello students, in this small video I will be depicting the principle of dynamic compression plating in simple diaphyseal fracture. So this is a kind of fracture which can be treated with a dynamic compression plating or shaft humerus fracture. So this is an image representative of a diaphyseal fracture which is displaced in nature. So the first thing that needs to be done is to reduce this fracture using bone holding process. Once it is provisionally reduced, you can secure it with a K-wire also, which is optional in nature, and or otherwise you can position the plate over the fracture site and then secure the reduction using plate holding forceps. Here we have used a dynamic compression plate of 8 hole size, and 4 holes have to be positioned on each side of the fracture. So this will be the look that you will be getting after positioning the plate over the fracture site. You can see 4 holes are there on each side of the fracture. This will be the view when viewed from the front, or you can call it a frontal view, and this will be the view when viewed from the sides, or you can call it a lateral view. In the lateral view you can see the holes of the plate are viewed in form of their cross section, and you can see this part appears to be curved. So actually this part simulates a curved cylinder, and once a spherical object moves inside this cylinder on the periphery, that means this part, that a spherical object will glide in this part so that it gets seated in this region. We'll be coming to the example in coming slides that will make the things more clear. So the first screw that needs to be drilled in compression plating is centric in nature. That means it has to be drilled in the central position. So you have to select the appropriate size drill bit, drill the track, and this will be the drilling track that will be appearing after you have drilled it. So this will be central in both frontal and lateral or sideways views. So once you have tightened the screw, it will get seated at a central position, and the curvature of the slot will not affect the screw position, or there will be no motion of the fragment. So this will be the final position of this screw once this has been tightened. Now the second step is to put a screw on the other side of the fracture, and here you have to pay attention. Why? Because this screw needs to be drilled in eccentric mode. Eccentric mode means that it has to be drilled away from the fracture side and closest to the outermost part of the slot meant for the screw in the plate. So this will be the drilling track, and be aware when you are using manufacturer specific drill guide, the arrow needs to be directed towards the fracture site. When the arrow is directed towards the fracture site, it will automatically result in an eccentric hole. So when you are pointing the arrow towards the fracture site, you will get this kind of drill hole. So once the drill hole has been drilled, then you have to put the screw, and once this part, the spherical part of the screw head, touches the outermost part of the cylindrical slot of the plate hole. Then there will be motion at the fracture site. Why? See, this part has to get seated inside this slot, and for this part to get seated inside this slot, there needs to be displacement of whole fragment from here to here, and the screw as well. So this will automatically bring compression at the fracture site. So you can see this mini clip in which you can see the motion of the fragment. The only thing that is happening here is that the screw is getting seated inside the hole, and that is actually bringing the motion of the fragment towards the opposite side, and this results in compression at the fracture site. So this motion will result in 1 millimeter of compression.
So this is the mechanism of the compression, dynamic compression plating. But the simplest way to explain it, I'm sorry to out of the video was not perfect, but we don't want
Eccentric hole
if you keep
on
another
the same
eccentric,
side of the fracture. Once you have drilled it, then again in a similar fashion you have to position your screw. But before tightening the screw, so that the head gets engaged inside the slot, you have to release this head. Why? Because this head is already engaged inside this hole, and it will prevent the motion of this block towards the fracture site. That means it will prevent the compression at the fracture site. So you have to loosen this screw so that there is some motion of this fragment towards the fracture site. So once you have loosened it, then you have to tighten this third screw. And when this screw is tightened, again in similar fashion, there will be gliding motion of this spherical screw head inside this curved slot, and this will result in further compression. Now once additional 1 millimeter of compression has been achieved, you can finally tighten this screw. This will not affect your compression. Waiting for a simple diaphyseal fracture. If you have any query,
this video is very complete about the section of the transfer fracture with dynamic fluid. It shows the same concept, but it introduces several devices that are being used in technique. It is useful for you to watch it later because the technique is the same thing you saw in the previous video, but the devices that it introduces, the guide and how the guide works for the drill bit, because the guide you put into the hole of the plate and it can place your drill bit in the correct location, eccentric or centric. And we have some pattern and bone ability to introduce everything for you. And the connected device with the video is very trying to be familiar with the real device. And this is Buttress plate.
Fixation of a bicondylar fracture of the tibial plateau using the LCP 4.5, 5.0 proximal tibia plate and the application of a bone substitute, in this case Chronos Inject. Bicondylar type C fractures of the tibial plateau are multifragmentary articular fractures, characterized by the involvement of both the medial and lateral plateaus. As a rule, on the lateral side there is usually considerable comminution and impaction of the articular surface. On the medial side, there is usually a large bone block that has been avulsed or sheared off in one piece. The model shows a large bone block medially and considerable comminution laterally. Stages of reconstruction. Preoperative. planning. Reduction and fixation of the medial plateau. Reduction and fixation of the lateral plateau. Injection of a bone substitute, chronos inject, into the lateral bone defect. Preoperative planning and incisions. The patient is positioned supine on the operating table with the injured knee flexed approximately 60 degrees. The uninjured leg is lowered so that C-arm images can be taken in both AP and lateral planes. To fix such complex injuries, 2 separate incisions are preferred, one posteromedially and one laterally, in order not to interfere with the delicate soft tissue cover over the tibial tuberosity. The patella and the lateral and medial joint lines serve as landmarks. Reduction and fixation of the medial plateau. First, a straight posteromedial incision, and second, fixation with a 1/3 tubular plate, or an LC-DCP 3.5. The medial incision is directly dorsal to the pes anserinus, which is elevated or partially incised, depending on the fracture configuration. After clearing the fracture gap, a reduction is achieved by pushing the medial bone block upwards. Preliminary fixation is done by inserting a K-wire. This preliminary fixation is begun close to the joint surface. Then the K-wire is angled downwards, so that it ends in the tibial shaft. A 5-hole 1/3 tubular plate is positioned on the posteromedial crest of the tibia. Only minimal plate contouring is required, if at all. Next, a 2.5 millimeter hole is drilled, just distal to the apex of the fracture, using the appropriate drill guide. A depth gauge is used to measure. A 3.5 millimeter tap and corresponding sleeve are used to cut the threads. A Cortex screw is inserted through the middle hole of the plate. This maneuver pulls the plate into its anti-glide or buttress position, thereby reducing the fracture indirectly. Next, a Cortex screw is introduced through the most proximal plate hole. After placing the most proximal screw, the first screw will need to be retightened. The K-wire must now be removed. The third Cortex screw is inserted through the most distal plate hole. At this point, an intraoperative X-ray is advisable, as in this clinical example. Reconstruction of the lateral plateau. First, exposure of the tibial articular surface through a straight lateral approach. Second, reduction of the impacted joint fragment. Third, lateral buttressing with a plate and screws. Fourth, filling the defect with a bone graft substitute. Chronos inject. For the surgical approach, a skin incision is made running laterally to the patella and tibial tuberosity. It proceeds directly down to the bone without separating the tissue layers. In the clinical situation, the knee joint is opened by a horizontal arthrotomy distal to the meniscus. If the meniscus is torn, it's now advisable to place 2 or 3 resorbable sutures into the rim of the tear for later reattachment. To fully appreciate the extent of the damage to the lateral condyle, the condyle is gently opened through the anterior fracture line. The central impaction is elevated with a pusher. After reducing the lateral construct, the reduction is held in place using the large pointed reduction forceps. A 4.5/5.0 LCP proximal tibial plate is placed to support the lateral condyle by buttressing it. Alternatively, either a T-buttress plate or a tibial head buttress plate can be used. The LCP is fixed temporarily with 2 K-wires, as shown here. Before placing any screws, it's advisable to check the quality of the reduction with X-rays in 2 planes. The first screw is inserted through the plate hole, just distal to the apex of the fracture. The 4.5/3.2 universal drill guide is used in the neutral position. Both cortices are drilled through, using the 3.2 millimeter drill. After measuring and tapping, the 4.5 millimeter Cortex screw is inserted. The 5.
As you see here, up to now, there is a screw here, this started the fracture, and this construction is buttressing the fracture. The rest is fixation. We put some screws here to fix the fracture together, the lateral condyle with medial condyle, and different parts in the shaft. But the buttressing mechanism was here. Only between this screw and the plate on the fracture side. And if the plate will fix with the shaft without a screw, if you put pressure on this segment, it will not slide down, and we do not do the reduction because the arterial node is converted to compression node and compresses the fragment to the shaft and the other fragment, and in this way there is no displacement. This is called buttressing. The rest is putting some screws, and this is a locking compression plate. The third is some locking plates, locking the screws here.
Zero-threaded LCP drill sleeve is screwed into the most anterior of the proximal plate holes. This drill sleeve will show the direction of the most proximal locking head screw. The plate is secured to the bone proximally by using a 4.5 millimeter Cortex screw. The 2 Cortex screws are tightened sequentially to maximize the buttress effect. The anterior K-wire is removed to avoid collision with the drill used for the anterior hole of the proximal end of the plate. A hole is drilled using the 4.3 millimeter drill bit. The screw length can be taken from the markings on the drill shaft. The drill sleeve is removed. The 4 Newton-meter torque limiter is used to insert a 5.0 locking head screw of the appropriate length. After beginning with a power tool, the insertion is completed by hand, using the large hexagonal screwdriver with integrated torque limiter. The posterior K-wire is removed. The more posterior plate holes in the L plate are usually hard to reach through the anterior incision. A separate stab incision is appropriate. A second locking head screw is inserted through the middle plate hole of the proximal end of the plate in a similar manner to the first one. The proximal fixation is completed by using a locking head screw just proximal to the apex of the fracture. Finally, another locking head screw is inserted through the most distal plate hole.
Growing up, I was a little slower developing physically than most other kids. Sitting up, rolling.
Injection of a bone substance.
The next step is filling the defects with bone graft. Sometimes we use bone graft from the patient. Sometimes we prefer to have synthetic bone graft, but here in the video, it explains how to do the bone graft with the synthetic one. We will discuss it later in another session about
Substitute.
And this is a neutralization plate.
A type B malleolar fracture. AO classification 44B. A type B malleolar fracture is caused by a pronation eversion mechanism. The trochlea of the talus is forced and rotated externally. The result is the fibula fractured in a spiroid fashion starting anteriorly at the level of the ankle joint. The distal fragment of the fibula is displaced proximally and slightly rotated. In about half the cases, the anterior syndesmotic ligament appears to be injured. However, the posterior ligament remains generally intact, but may avulse a posterior lip fragment of the tibia. On the medial side, the deltoid ligament may be torn or the medial malleolus fractured, showing typically a horizontal or transverse fracture plane due to the avulsion mechanism. A rather unstable and displaced type B fracture is best stabilized with a 1/3 tubular plate. To function as a buttress or anti-glide plate according to Weber, the plate must lie on the posterolateral aspect of the fibula. The straight skin incision is made along the posterior ridge of the fibula to prevent any interference with the superficial fibular nerve or the sural nerve. A 5-hole 1/3 tubular plate is chosen, where the oval hole may be used for axial compression. The instruments needed are the pointed reduction forceps and the toothed reduction forceps. Also required are the 2.5 and 3.5 millimeter drill bits, the 3.5 2.5 double drill guide, the depth gauge, the 3.5 millimeter tap with handle, and the small hexagonal screwdriver with holding sleeve. Usually, reduction is best obtained by placing the 5-hole plate without contouring onto the posterolateral aspect of the fibula. By applying the small toothed reduction forceps over the plate, the spike of the distal fragment is automatically reduced and held in its correct position. 2 plate holes should lie over the distal fragment and 2 over the proximal fragment. The middle hole may be used for an interfragmentary lag screw. The first 3.5 millimeter cortex screw is inserted through the plate hole just proximal to the fracture. With the 2.5 millimeter drill bit and corresponding drill sleeve, a hole is prepared through both cortices. The length is measured with the depth gauge. The thread is cut with the 3.5 millimeter tap. The appropriate length 3.5 millimeter Cortex screw is inserted. By tightening the screw, the straight plate is pressed against the slightly curved bone. The result is a spring effect that increases stability. If the reduction is not perfect, the screw should be loosened and the distal fragment gently manipulated with the pointed reduction forceps. A 3.5 millimeter Cortex screw is placed eccentrically in the most distal plate hole in the usual manner. To improve fixation, an interfragmentary lag screw is added through the middle hole of the plate. The 3.5 millimeter drill is used to create a glide hole in the near cortex. The 2.5 drill sleeve is inserted into the glide hole, and a 2.5 millimeter thread hole is drilled in the far cortex. The screw length is measured, and the thread is cut with the 3.5 millimeter tap in the far cortex only. The 3.5 millimeter lag screw is inserted, producing extra compression across the fracture. Finally, another screw is placed in the most proximal plate hole. With this kind of anti-glide plate fixation, the fracture is firmly locked and so stable that immediate weight bearing may begin.
What does a yes vote on the sewer sale mean for Gloucester Township? The system will be sold to New Jersey American Water.
As an alternative, the same 5-hole 1/3 tubular plate can also be placed on the lateral aspect of the fibula, combined with an independent lag screw across the oblique fracture. Here, the postero-anterior direction for this screw is preferred instead of the anterior-posterior direction, which needs considerably more dissection to place the screw perpendicular to the fracture plane. The fracture is reduced with the reduction forceps that are placed so as not to interfere with the planned lag screw. The 3.5 millimeter drill bit and matching drill sleeve are used to prepare the glide hole slightly oblique to the fracture plane. The 2.5 drill sleeve is inserted into the glide hole, and the 2.5 millimeter thread hole is drilled. Measuring and tapping is done. The 3.5 millimeter lag screw is inserted to compress the fracture. The 1/3 tubular plate is prepared by flattening its profile with the.
So you see here, the fracture in the second option is fixed with a screw called lag screw. We discussed it in another session in detail. It is single or double screws inserted into the oblique fractures and spiral fractures. For compression, it is enough fixation, but for axial loading, it is not enough. That is why it has placed to the lag screw, which is inserted first, the lag screw is inserted first, and then we add a plate to neutralize the axial load. That is called neutralizing plate. The first one that with the lattice screw through the plate was not a neutralizing plate, it was a regular plate. It the plate applied compression to the fracture. We reduced the fracture by putting the plate and fixing the plate to the bolt. So the plate applied the compression, but for second option you see here, for the lateral malleolar fracture, you see the fracture was reduced and fixed with the lattice screw, but it's not enough. So axial load, so this is neutralizing. The rest of the plating is determined the other one. So
Parallel
then any questions? No?
Yeah, quick question, because in two of those videos, it had the plate, it looked like it's going over on some of the ligaments. Does that hamper the ligament's function when applying the plate?
Oh, we must put the plate somewhere that does not interfere with the ligament. So we don't put the plate over the ligament. We put anterior, distal, posterior, somewhere around the ligament, not over the ligament. When the reason why there are so many shapes for different shapes for the plate for around the joint is the problem. You must stay away from the major vessels. You must stay away from the cutaneous nerve. You must stay away from ligaments. So when you consider all these structures, you have a little space there to put your plate. So you need a specific type of, a specific shape of plate to match that little space. That is why different shapes of the plate are produced to match those specific parts. Any other questions?
Yeah, during the compressive plating, is there ever times where like the bones collide too early and the screw doesn't go all the way in, so you kind of have to redo it? Or are you like non-stop X-raying so you know exactly where the bones are coming together?
Yes, sometimes you mean the amount of compression we are applying is too much for that gap that we have. So yes, the bone reach together and the screw cannot move forward. It happens, and we leave the screw there. We don't do anything, and we try in next session. We are going to discuss the different imaging techniques. One of them is fluoroscopy. Fluoroscopy is the live imaging of the fracture size and surgery. We use fluoroscopy, but we try not to use them frequently. No, we just know that the screw cannot be tightened anymore, so we leave it there. But remember, everything you saw in this session, except the buttress concept, buttress plating concept is still working even with locking plate. The rest of things you saw was the basic concepts about the plating, but with the new design called locking plate. These concepts are not in common use. I wanted you to be familiar because you hear about them. Sometimes some surgeons use, and sometimes you need to use those concepts, but they are not common practice now. Next session is the common practice. And you will see next session how locking plate revolutionized everything in orthopedic. Okay. Any other questions? No? Okay. Enjoy your evening. See you tomorrow. Tomorrow is Thursday, yeah? See you at 5. Okay.
Good night.
Thank
Have a
you
good day,
so much.
Professor.
Thank you.